Primary ciliary dyskinesia is a rare genetic condition which can affect many children. It is called as autosomal recessive condition. In this, what happens is the cilia, or these are small like hair structures which are present in our upper, lower, even our eustachian tube, your inner ear, or even in children where it can involve the middle ear and sinuses. Now, these hair-like structures in women are also present in the fallopian tubes and in males in the seminal vesicles or the sperm cells. Now, in PCD or primary ciliary dyskinesia, these cilia are not very well developed. They can either be structurally abnormal, or if they are present, they are not functioning or not moving in the right direction. These cilia, which are present on our respiratory tract, have a to and fro movement, and this to and fro movement helps the respiratory tract to get rid of infection, mucus, and a lot of other secretion. Now, if the cilia are not functioning well and they are not moving in the right direction, or if there is any structural abnormality, the mucus will keep collecting in the respiratory system and it will be a nidus for further bacterial infection. If this infection keeps on growing and there are other superadded infection, there is a chance that the lungs can be permanently damaged and it can lead to what is called as bronchiectasis or chronic lung disease. Primary ciliary dyskinesia, almost 80% of the children can present at term. When a term child presents with respiratory distress, it should always think that there could be a chance that this child has got primary ciliary dyskinesia. So it's important that you know a detailed history and do a complete clinical examination of such children. The most common presentation is recurrent chest infection, recurrent sinus infection, or mucus production, or even infection of the ear where these children present with acute suppurative otitis media. The nasal cavity inspection can lead, if you can see, presence of nasal polyps as well. To know more about how the diagnosis is done, there is not a single test which can be able to diagnose PCD. We usually start with the screening test, which is called as a nasal nitric oxide test. In this, we measure the level of nitric oxide and see how it is. In children with PCD, this nasal nitric oxide is very low. Then on, we can also do what is called as nasal brushing. In nasal brushing, there is a nasal brush which takes out a part or a scraping of the nasal epithelia, which can be seen under a microscope to see what is the function or the motility of the cilia. If the cilia, if they are present, are they moving in right direction, or they're just moving round in a direction which does not help propagate the mucus. If there is any signal that the cilia are not moving in the right direction, we do the electron microscopy. Now, these cilia have a certain structure. If this cilia, now they have what is called as outer Diane arm, inner Diane arm. There are microvascular tubules or radial spokes. Now, these are the various forms of structure of the cilia. If there is any damage in any of these parts, it can cause non-functioning of the cilia. There is also a genetic test which can be done to know what are the multiple genetic defects which can be seen in the cilia. Now, this motility disorder, once it is being diagnosed, what are the treatment options? Well, since we don't have a single treatment modality, improving the quality of life, preventing chest infection, chest physiotherapy to increase mucus clearance of this respiratory infection and mucus forms the basis of treatment. So, physiotherapy, chest clearance technique or airway clearance technique forms a very important part. Many times this kit might require long-term antibiotics therapy and even nebulization or even inhalers. The best modality would obviously be a lung transplant or a stem cell transplant whenever possible. But improving the quality of life, preventing chest infections and sinus infection forms the basis of treatment of PCD. Thank you.